The speaker is Dr. Shom Shattok. He is newly joined in Apollo with me as an associate consultant. He's done MBBS from Mednipur Medical College and MD Anesthesia from Medical College and DM Critical Care from All India AIMS New Delhi. And the panelist is Dr. Anirban Chattopadhyay, is senior consultant in CMRI hospital, and also other panelist Dr. Shoham Majumdar is a senior consultant both Amri and Bellevue, and Dr. Manos Ghosh is a associate professor, assistant professor in কল্যাণী জেএনএম তুমি মুর্শিদাবাদ চলে গেলে বললে আচ্ছা জেএনএম মেডিকেল অনির্বাণ নিয়োগী is from Bellevue and is one of the well-known figure in both pulmonary and critical care society. So Dev Kamal also here. So now we will start. Dev Kamal samne chole aaye. Dev Kamal is budding consultant in CMRI. Budding. এখন আকাশে উড়ে গেছে. So Shom Shattok will present a case that is basically one interesting case who presented with one complication, one simple complaint, but find out there is a multiple problem. So let's start.
Hello, good afternoon. So I shall be directly going to the case presentation. 84 years old male patient who presented at the emergency department of a hospital, Apollo Kolkata. He presented with typical features of lower respiratory tract infections, expectoration, sputum, fever, shortness of breath for last 2 days. He had morbidities. He is a known diabetic for last 10 years, hypertension for similar period of time, and also a known case of COPD. He was not hospitalized in the last 2.5 months. On examination, he had a poor GCS, E3, V3, M5. He had tachycardia, tachypnea, hypotensive, and he was not maintaining his saturation. It was around 80 to 85% on NRBM, 10 liters per minute. On examination, he had chest findings were bilateral crackles and decreased air entry. So in view of the altered GCS and hemodynamic instability, sorry for the spelling, he was intubated and treatment was started as per the sepsis protocol, and the usual cultures, the sputum and the blood cultures were sent. And in view of because he was requiring noradrenaline support, so CVC in the right IJV was inserted, and for the hemodynamic and blood pressure monitoring, arterial line was secured. A chest X-ray and HSCT chest were done. And as per the hospital protocol, the antibiotics started were piperacillin and tazobactam along with doxycycline. So this was his ABG. The ABG showed the lactate of 2.5 and some acidosis. Base excess was -5 and bicarb was 17. The initial investigation showed a TLC on the higher side, 14,000, and the rest of the investigations were more or less within normal limits. This was his chest X-ray showing bilateral opacification and some pleural effusion on the right side. This was his HSCT, which is showing obviously infective changes bilaterally.
So now question is that the patient admitted with respiratory distress, and you have seen the lactate is higher. So, Som, the first question to Som, what is your initial diagnosis of this patient, and how will you approach?
See, because no obvious consolidation in the CT scan, there is a generalized ground glass opacity. So, bacterial consolidation by the CT scan is relatively unlikely. But obviously the count is high, WBC count is high. And any CRP, procalcitonin, any marker is there?
CRP is little higher side, but portal considered is normal.
So obviously one bacterial infection DD will be there, but along with that any history of travel or anything else or any exposures, that is also be important in this case, because some tropical infection with the pulmonary involvements, some the creatinine and the other urea creatinine level is there is not.
So that means you are thinking about the community acquired bacterial pneumonia, or there must be a viral
Involvement or tropical.
I should go for diagnosis of atypical pneumonia and viral pneumonia in this case. PCT is normal, patient in shock, and TLC is not much higher. So typical bacterial pneumonia has been our last DD. Before that, viral and atypical pneumonia will come.
So yes, I agree to that, because the HRCT is not a lobar consolidation, it's more of a ground glassing. Other diagnosis DD will be like you need to rule out any cardiac causes, pulmonary edema, cardiogenic shock, and since the patient is quite old age, so there is chances that chronic aspiration might lead into this, and so we need to consider those things in mind. Obviously, if you are getting a hypotensive patient like this, so then start with antibiotic septic shock protocol, but obviously our other diagnostic criteria are also kept in mind.
Thank you. Obviously said it is a blood sugar is around 230, 180 to 230 range. We have given the insulin sliding scale to them, and we will focus on the diagnosis. Initially it was found that there is a H1N1 in the first nasal swab is showing. So we have treated with community acquired, taito. So community acquired pneumonia, and he was quietly well. But since admission day, there is a complaint about that there is a abdominal discomfort. Though abdomen was soft, but there is a history of constipation and little bit abdomen is distended. So subsequently, on day 3 of ICU stay, the abdominal distension has increased and abdominal growth also increased. So we have done state X-ray abdomen, the general surgeon referral given, and general surgeon has seen this patient, and he is suggested for the CCT. CCT, okay. So this is the CCT of this patient, and it is showing that impacted stool, nothing else. So that time they decided, the general surgeon decided to go, call for your gastroenterologist for evacuation, sigmoidoscopy and evacuation. We did that, but patient not improved. Then finally we decided to operate this, and for the decompression, because by that time, due to the abdominal distension, there is a development of abdominal hypertension, and the urine output has reduced. So AKI developed. So that's why we have done the surgery, and we have operated, and they decompensate these things. Okay. So after that, the patient urine output again improved, the AKI resolved, patient extubated, patient was good, but from 5th day onward, there is again rising of oxygen requirement, no fever, only rising of oxygen requirement. So patient need NIV support and the count has increased. So what other investigation will do at this moment, Dev Kamal?
We have to repeat the chest X-ray at that point of time to look for any new onset of increase in opacity or not, whether the patient has developed, since it is a post-op patient, there may be associated pleural effusion accumulating again. So
What are the DD? Only chest or something else on other infection also? Because it's a
post-operative case, most probably he has a GI surgery. What was the surgery done? Only evacuation.
No, they have done the ileostomy and the decompression of the colon.
Decompression of the colon, so we need to think about any fungal infection going on, because post
What are the investigation you will say?
I will send another set of blood culture. The patient is not intubated at this point of time, so if he is able to produce any kind of sputum, I'm going to send that for culture. I want to repeat the counts, check for the procal, see the infective markers, and repeat X-ray. The X-ray I told at the first time. So we can do the lung ultrasound and see whether there is any kind of accumulation of fluid or not.
Exactly, we have done the chest X-ray. It was showing that it asked it. So we have done the repeat chest X-ray and also we sent the blood culture and the count was a little bit higher, around 22,000 that time, and the ABG also worsening, so hypoxic and the lactate is high, and we have intubated again because of desaturation and hypoxia and develop hypotension also. So it is a new onset sepsis is going on, and the ET aspiration is showing Acinetobacter baumannii complex, and it is showing the colistin and the minocycline intermittently sensitive. So so what antibiotic you will give? So MDR acetato, only minocycline and colistin intermittently sensitive. So what antibiotic choice?
So I agree with the polymyxin group of antibiotics, but I would rather start a polymyxin B rather than a colistin, and minocycline can be continued because it has a good lung coverage and Acinetobacter is sensitive to it.
Plus minus colistin nebulization. Plus minus colistin nebulization. Colistin I means that is the CLSI or there is a cutoff value of MIC is less than 0.5. I hope that is so.
So Manas, do you want to give along with sulbactam in this patient?
Practically, I do not use separately the sulbactam because
Combination, because it is a intermittent sensitive.
yeah.
On polymyxin, intermittent sensitive on minocycline. So both are intermittent sensitive. So
Rather, in that case, I will prefer both the colistin as a nebulization and also the IV therapy.
monotherapy you want?
No, not with the
Combination therapy with the
both the from nebulization and the IV.
Your opinion?
I would like to add sulbactam to the regimen, because according to the latest IDSA guideline, whatever the sensitivity of the crab means carbapenem resistant Acinetobacter, we should include sulbactam in the therapy along with polymyxin and other susceptible drugs.
So latest guideline of Acinetobacter baumannii is showing if it is a minocycline sensitive, go for minocycline monotherapy. If it is not, then whether the clinical scenario suggestive mild, moderate or severe. In mild or moderate cases, you can go for the colistin and the minocycline. But if it is a patient is critically ill, then you can go for the minocycline, polymyxin and the sulbactam combination. So we have started minocycline, the sulbactam along with it, and doxycycline continued till 5 days. Initially, because of cap, we have continued with the doxycycline. After 5 days, we stopped this doxycycline. Okay.
But the IDSA guideline is that only sulbactam is the ampicillin.
No,
Yeah, they are using ampicillin.
Ambicel. But here we use the sulbactam separately.
Sulbactam, if you are using separately for Acinetobacter baumannii, then it needs to be high dose and needs to be given like 9 grams TDS. That is because the patients are usually the urea creat, those things are high, and AKI feature is almost always there in sepsis patients. So practically it is very difficult to use 27 grams of sulbactam per day. So like theoretically sulbactam is very good as a monotherapy, but usually it's always used along with the poly B and minocycline or like that. Thank you.
So next this is the ABG on the day 6 and the chest X-ray. So change karo?
Worsening metabolic acidosis.
So there is a patient intubated. You have given the triple drug therapy. Still patient is worsening. So what will you do? This is the lab. The count is increasing, platelet decreasing. Serum albumin is 2.8. Okay, then noradrenaline need rising, lactate. Yeah, heart is okay. There,
No collections in the abdomen.
no collection in the abdomen. Kidney is also okay right now.
Higher in the urea just.
So what drug we have not given, any gram positive we have not given till date. So again we have sent it the set of culture. We are able to Kire bhai
মাইকটা রে
okay. So in that time that the two important thing in the culture, one is the gram positive come, and second, this time minocycline is resistant.
ডিজি
So what?
He was resistant from beginning. First one was resistant.
So what are the antibiotic you will given? Anirbandha কি অ্যান্টিবায়োটিক দেবে?
রিপিট কালচারে অ্যাসিনেটোব্যাক্টার
রিপিট রিসিকালচারে অ্যাসিনেটোব্যাক্টার রেজিস্ট্যান্ট আর হচ্ছে এন্টেরোককাস ফিসিয়াম এসেছে। মানে ইনিশিয়ালি দেওয়া হয়নি, মানে তখন তো হচ্ছে আমরা ওই গ্রাম নেগেটিভটাকে ইয়ে করছিলাম।
Now the problem for the PCM, the sensitivity is that ticoplanine or vancomycin was there.
I was coming to that. It was vancomycin resistant.
Yeah,
and
that will linezolid cannot be given. Then TAP2 will be the preferred choice for the CVC patient.
একদম।
Because the introphysium, the problem is that they are a Van A and Van B gene producing is much higher than the enterococcus faecalis. So if it is VAN-A or VAN-B mediated, then VANC and ticoplanin are both will be raised. And the linezolid is the tissue will be there and the lung will be there, linezolid will be the good one along with that. But for the dapto purpose, it is seriously. If it is the bloodstream infection, it is again the problem is the dapto for the enterococcus faecialis, there is no cutoff. Because dapto, the dose is the 670 per kg. That is not recommended for the enterococcus faecialis. That is not recommended for the enterococcus faecialis. So dapto probably 10 mg per kg. And if that is not well accommodated, then along with the fosfomycin plus minus or along with the levodopa plus minus, this combination probably will be the better for the resistant enterococcus faecium bloodstream infection.
No,
Linezolid cannot concentrate in the blood. So if it is a bloodstream infection, linezolid will not work. Linezolid is good for tissue binded and the plasma protein binded. So free drug
and
is not
also
available
another
in the
problem in the linezolid here, the thrombocytopenia. Already the patient have thrombocytopenia, and obviously it is not work in the blood. So Anirbandha, what is your opinion about the this levodopa in this case?
Now I used a couple. For the physium, again the levodopa data is small, is along with the combination of the fosfomycin is some data, but monotherapy for the physium is not.
So Anirban, what is your choice of antibiotic over here? এটা চলছে না খুব একটা।
Point that customizing would be a good choice, but I think apart from that, take out the line. So you have to take this IV line, central line, put a new one, and start with the daptomycin would be better over here.
So now thing is that আরে ভাই মাইকটা ঠিক কর, হয় বাজা নালে বন্ধ কর। ব্যাপারটা now the Anirban is absolutely right that when there is a bloodstream infection, it is better to remove all the line and send for the CRBSI. So what is your opinion between CLABC or CRBSI? What is your?
It is probably a CLABC rather than the CRBSI, but it is not fitting the criteria of the CRBSI because there is no DTP, differential time to positivity of the culture, or any TIP cultures positive for that. So it is a CLABC, remove the line. Obviously, if there is a biofilm there, that will be removed also. Resistant breakers, still I am not confiding in that.
Regarding the Manos resistant breaker, use of resistant breaker at this point.
Hello?
Resistant breaker, like antibiotic resistant breaker, any role of this type of cases?
Like
Like
I have found no guideline regarding gram positive with all the recommendations coming for gram negatives.
it is both the gram positive also, gram negative also.
We may add if there is no bleeding tendency, we can add. If there is no coagulopathy, we can add. I have no idea regarding any gram positive where we can indicate it EDTA can be used.
If you take out the line, that will serve the purpose. No need to use any R breaker, I think.
Anirban?
I have seen EDTA, as Anirban has said, it's a relatively harmless molecule. It has and a dose you can increase the dose a lot, and the resistant breaker dose that we are giving is very less. So I don't found anything good or bad about it. I have seen many people using EDTA, and I personally don't use, and many people don't use, and I don't have any comparative study whether adding a EDTA giving us a better result. But if it is having some theoretical advantage and if it is relatively risk-free, then I may take it. But I have no first-hand experience or any society guideline to use EDTA in every patient.
So finally, we kept this patient on. We have stopped the minocycline because it was minocycline resistant, and we kept polymyxin B and the sulbactam little higher doses, 3 gram TDS, and total 9 gram. And for the positive enterococcus faecium, we have kept the daptomycin, and then finally patient started improving. So become afebrile, record of the noradrenaline reduces, and this is the latest ABG, and we have extubated and doing well. Probably patient will discharge day after 2-3 days. Right now patient in with us. That's all about my case.
In two questions basically. In the first case, it's a crab. So IDSA said sulbactam should be the first along with the minocycline. And why do you have sulbactam darlobactam combinations? It's right now available. Yeah. In Medica we are using, but they are procuring from outside, but the pharmacy. Because the thing is, for sulbactam, there are PVP3 bindings, and along with C and D, and darlobactam, they also cover the A and C. And first of all, this, and so sulbactam, darlobactam, 2 gram QDS plus minocycline, 200 load, 100 BD will be the better choice. Along with the, if we colistin nebs, it's not recommended till now, but it's not feasible. Because the thing with polymyxin B is we measure only the colistin MIC, and it is intermediate for a purpose that it will be not a overused. And the polymyxin B pharmacokinetics is for lung is erratic. It's better for drug for blood, but lung yes. For colistin because that's so. And the thing for enterococcus, is there any metastatic infections or that has been ruled out or not? No, I am saying on the first, when there is fever and all those things.
Excuse me, sir. There is one question from my side. What the dose modification in renal condition when patient is in chronic renal failure? What the dose modification? Yes. 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 Understand. Okay. Thank you.
Thank you so much, sir. Thank you.
C plus স্টলে যাচ্ছি আমি
স্যার স্যার একটা সেকেন্ড প্রসেনজিৎ কোথায়
অনুযায়ী আরে কি আগে কথা বলতে পারবো না সবাই
Thank you, sir. Thank you. Thank you so much, sir. Thank you so much, sir. Sir, कितना दो सर कितना? Thank you, sir. Thank you. আরে ফ্যাকাল্টির অরিজিনাল যারা ছিল তারা কোথায়? কি করতে হবে বলুন তো স্যার? মাইকটা ধর, মাইকটা ধর। আমি আর মাইক ধরে